Hi everybody, back again. We're almost finished with this week. 2 more to go. This one is on Unit 4. Again, Week 1, Unit 4. This is the second one, or B. This is on in Chapter 11 in your book. It is Pediatric Pharmacology. It is also in the old book. It'd be Chapter 10. In the new book, in its 7th edition, it starts on page 176, if that's helpful. Okay, we're going to go through some pharmacokinetics on this. Pharmacokinetics, of course, as we've talked before, is defined by the study of time in the course of the drug absorption, distribution, metabolism, and the excretion. I'm sorry, getting organized here. Absorption is based in the child on the child's health status, the route of administration, except in the adolescent hormones when they come into play, because that causes poor absorption. Otherwise, as the child grows, the absorption increases. So neonates, babies, it's slower. Always look at kids' hydration status, and you can tell that just by feeling their skin. Think about their underlying disease, the GI disorders. All of these things, they can affect absorption. Drug absorption is mainly dependent on the route that the meds are given. For PO meds, consider all the GI factors that are in play, especially with these little guys. A lot of the nausea, vomiting, diarrhea. Remember, neonates and infants, they don't absorb GI as well as the toddler. Gastric emptying is also delayed in babies, but it increases as the child grows. Nurses need to be aware that delayed emptying reduces the peak serum concentrations. Breastfed babies breastfed babies have longer GI transit times than bottle-fed. Also, the more frequent the feedings, the less time food is in contact with the gastric lining. Of course, like we said, vomiting and diarrhea decreases absorption time available, especially peds meds that cause diarrhea. So a lot of them do cause that, so be aware of that. Meds given sub-Q and IM, the absorption occurs at the tissue level. Conditions that affect perfusion will affect the med absorption. Examples of that is dehydration, a cold if their body's cold, their cardiac status. IV meds now, they go right to the bloodstream. So they are absorbed systemically almost immediately, within seconds. Topical meds, on the other hand, are absorbed readily in children due to them having thinner, more porous skin. They also have a higher BSA, so this increases their absorption and may cause unwanted effects, so you need to be aware of that. I'm sorry if I'm stuttering a little bit. Peds is not my forte, so I am learning this along with you. It's a good review course for me. Alright, let's go to distribution. Distribution is affected by a lot of the meds in the old book. They give you a whole list on page 189, and it's again in chapter 11 for this course. There is a whole table with all the distribution, the effects. In the neonate and the babies, the body is 70% water, so think about that in your distribution. This ultimately causes a decrease in serum concentrations until about the 2-year-old. Then the pediatric client requires higher doses of water-soluble meds. They also have less body fat than the older child, so they require less fat-soluble meds. Less fat available always equals less medications that are needed. Drugs bind to proteins in the plasma. And you have to remember this. We talked about this before. They're protein-bound medications. Infants and neonates have less albumin than older children and adults. and they have fewer protein receptor sites. So this makes the med more available. So again, they need a lower dose. Think about that. Remember, anytime you have fewer sites for the protein-bound receptive medications to attach to, there's more free drug floating around in there, so you need a lower dose. Always closely monitor neonates and babies for effectiveness and any adverse reactions. You need to watch that and take care of them right away. Next slide is on metabolism. The infant hepatic function kicks in at about 2 months, so the nurse needs to monitor them more closely. Children have higher metabolic rates that cause metabolism to occur more rapidly. This may mean they need dosage increases, the pain meds especially in children. Since they metabolize that drug out of their system really quick, they need some more frequent medication dosages. Or if you give a larger dose, then you have to also watch for any of the side effects. After oral medications are given, they are subject to the metabolism in the liver. This is called the first pass effect. They pass through the liver before they're available to the tissue. For some meds, this first pass effect also must be calculated in the drug calculation. A lot of PEDS meds are given rectally to avoid that first pass. Also, meds that are given IV, they don't get that first pass. It's the PO drugs. So just to take that in consideration. Now the excretion, to get rid of that drug. Before 9 months of age, infants have a reduced ability to excrete meds because of a decreased renal function. So we have to think about that. They have a decreased glomerular filtration rate and a reduced renal tubular function. So nurses need to monitor renal function. You need to think about your urine output and your medication's effectiveness when you're looking at that. The nursing implications to this is it is important when caring for pediatrics that you monitor their therapeutic effect and their adverse reactions closely. So you're looking at serum levels and assessing the patient. Those are the ways to tell on these little guys. Medications are ordered based on weight. Chemotherapy is based on body surface area, and dosing must also consider the child's status, their age, their organ functions, health, and the route of the administration of the medication. Some more of the nursing implementations are that you must always confirm the patient's ID. Remember, they can't tell you, so you got to find other ways to find out. Make sure that you have the right patient, the right time, all those good things. Know the developmental stages of the child in order to provide the appropriate care. Also involve the family. And teach, teach, teach. You cannot teach enough. The primary concern of giving PEDS medications is maintaining safety with a minimum of restraint necessary. They're scared. So you administer the correct dose and provide comfort. Toddlers, they can be violent, negative, and they feel negative, so you use a firm approach. To use a firm approach, use their imagination if possible. Preschoolers are pretty cooperative, but they fear bodily injury, so they need to think they are having some control. Most pediatric medications are given PO, so the use of oral syringes on the side of the mouth pointed up towards the cheek works pretty good. Gently blow into their face and they'll swallow. Do not crush or dissolve any time-release capsules. Of course, that's with anybody. Don't give less than a 1-year-old. Anybody that's less than a year old, do not give them honey. There's a chance of botulism. Their bodies can't handle it. Do not ever add medications to formulas. Atraumatic care is a delivery of care that eliminates or minimizes the psychological and physical distress experienced by a child and their family. One way to provide atraumatic care is to numb sites before an injection or an IV. Use distraction and never inject a sleeping child. Protect IV sites. Use colorful Band-Aids. Don't give gluteal IM injection until the child has been ambulating for at least a year. Use, on these little guys, use the ventral gluteal, but preferably for injection sites on the infant, use the vastus lataris. The nursing process, the pediatric pharmacology, is always you have to assess the patient. Look at their age, their weight, their height, their developmental age, their health status, the history of drug use in the family, nutrition and hydration status, their cognitive level, and then the family and the child's understanding. Some potential nursing diagnoses is delayed growth and development, ineffective tissue perfusion, impaired urinary elimination, and knowledge deficit. In your planning, you always want to think about the child. State things that are goal achieved. Child receives drug dose based on assessment data. The child will be free of whatever within 2 days, say, or whatever is appropriate. In your interventions, always use appropriate references. Monitor the child closely. Communicate with healthcare providers. Correctly calculate dose based on the appropriate parameters. In your teaching for your patient and their family, let them know about the use of over-the-counter products. Report any side effects immediately. Advise breastfeeding mothers that a portion of drugs is excreted in the breast milk, so if they take a medication, the baby may be taking that same medicine. Keep meds out of reach of children. Use child-resistant containers for meds. And then to evaluate what you've done, determine the family member's knowledge concerning the drug dose, the schedule for administration, any side effects. Determine the child's psychologic and sociologic response. Determine therapeutic and adverse effects of the drugs. Okay, finally, practice question number 1. Children have higher rates of metabolism than adults. This affects the medication for pain in children in the following ways. Except, so this is an except question. A, higher requirement for medication. B, increased dosage. C, decreased frequency. And then D, increased frequency. I'm sorry. The answer is C, decreased frequency. Practice question number 2. Although adolescents resemble the physical appearance and organ structure and function of adults, their bodies continue to grow and require vigilance and monitoring. What are you monitoring? A, therapeutic and toxic drug levels. B, side effects of medications. C, the route of medication administration. And D, frequency of medication administration. The answer to that is the therapeutic and toxic drug levels. All right. Sorry, it's a little confusing. Long day. Anyways, I hope you're enjoying this. I hope it's helping you. There's one more to go, so take a break, and we'll go from there. Also, you should have received by now, I have given a study guide for quiz number 1 for this week's quiz to kind of help lead you in the way that you need to be studying. I've also attached the study guide for the exam number 1 and 2. That's not due until we finish this next week's a group of lectures. So I hope this is helping you, and I look forward to hearing from you all. Talk to you later. Bye.